Assalamu alaikum everyone. It's me Dr. Muhammad Naseem Shirzad, and today I am going to discuss with you all retrocaval ureter, which is actually a rare congenital malformation. In simple word, retrocaval ureter means that the ureter is lying behind the inferior vena cava. Normally, the ureter present in normal anatomical position is that the ureter is present interior or in front of the inferior vena cava. But what happened in retrocaval ureter? There is a problem that the ureter is lying behind or posterior to the inferior vena cava. So, to make it simple, this is actually the abnormality or the embryological abnormality in the development of the inferior vena cava and not of the urinary tract. So, it's important to understand that the problem is actually in the development of the inferior vena cava and not that of the urinary tract. So, for this, it's important to understand the embryology and the normal development of the inferior vena cava. You know that we have divided the inferior vena cava according to their development into three parts. The first part is that prerenal, or we call it suprarenal IVC, means the IVC which is above the renal vein, and that prerenal or suprarenal IVC is actually developing from the right subcardinal vein. Now the portion which is the renal called the renal segment of the IVC, and this renal segment of the IVC is important, and this renal segment of the IVC is actually developing from the right supracardinal veins, and this is normally the right supracardinal vein normally present posterior to the ureter, means the ureter is present anterior and the IVC is present posterior, and this portion is also developed from the right posterior subcardinal vein, and this vein is present normally. The ureter is present posterior and the right posterior subcardinal vein present anterior. So the segmental portion of the IVC is developing from two veins. One is called right supracardinal vein and the other is the right posterior subcardinal vein. From the anastomosis of these veins, the renal segment of IVC development occur. That's why it's important to understand these two veins, right supracardinal vein and the right posterior subcardinal vein. So in fetal life, the right supracardinal veins is lying posterior to the ureter, while the posterior subcardinal vein is lying anterior to the ureter. So what happened? The actual problem is occurring at this position. Normally, the IVC is the right posterior subcardinal vein disappear and the right subcardinal vein leading to the formation of the IVC, and the ureter is normally present anterior to the IVC. But if the problem occur and the posterior cardinal vein persist, so the persistence are due to the absence of the disappearance of the posterior cardinal vein, the ureter will be lying posterior to the IVC, and that's condition which we also called circumcaval or pre-ureteral vena cava. So there is a problem in the persistence or the problem in the disappearance of the posterior cardinal vein. So when the posterior cardinal vein fail to disappear or it remain persistent, leading to the inferior retrocaval ureter, which is also called the circumcaval ureter or pre-ureter vena cava. So this point is actually important, that normally the ureter's development, the renal segment of the IVC is developed from the right supracardinal vein and the right posterior subcardinal vein disappear. But If the right posterior cardinal vein fail to disappear or it remain persistent, this will lead to the retrocaval ureter. And again, the classification of this retrocaval ureter is also important, and this classification is called Bergman classification, and it consists of two types, type 1 and type 2. Type 1 is also called low loop. This is the commonest one, and it is also called the typical S or fish hook or J-shaped deformity of the ureter to the level of the obstruction, as I have shown in this IVP, and this is showing a typical picture of the typical S or fish hook or J-shaped deformity. So type 1 is the commonest one. This is low loop. Low loop means that it's occurring at the mid segment of the ureter. It means at the level of lumbar vertebra L2 and L3. That's why this is the commonest one, and that's why this is a little bit dangerous one, in a sense that it actually causing moderate to severe hydronephrosis in about 50% of the cases. And the type 2, which is called the high loop. The high loop means that this occur at the level of the renal pelvis or just about the piezo. That's why this is less common, and there is much of the time there is a mild hydronephrosis, not that of severe or moderate hydronephrosis which occur in type 2. So in type 1, type 1 is a dangerous, as it occur in a mid portion, cause moderate to severe hydronephrosis in about 50% of the cases. And one other things which is important, this was also all about the classification, that type 1 is a high loop and type 2 is high loop, and that is called sackled shape. This is less common and there is mild hydronephrosis. But the type 1 is a low loop. This is also called J-shaped, typical S-shaped or fish hook deformity. This is the commonest one. There is a moderate to severe hydronephrosis, and much of the time it needs surgical management, and it involves the mid ureter at the level of lumbar vertebra L2, L3. Now, this is also important when you are looking into the IVP, must look into the deviation of the ureter, and you should to exclude the other acquired causes of the retroperitoneal pathology that leading to the deviation of the ureter. For example, retroperitoneal fibrosis also leading to the deviation of the ureter. Retroperitoneal mass can also lead to deviation of the ureter. So how to differentiate it? Like in case of retroperitoneal fibrosis, one differentiating point is that in retroperitoneal fibrosis both the ureter are involved, and the second important thing is that the whole segment of the ureter is stiff. And in retroperitoneal fibrosis there is a medial deviation just like that of the retrocaval ureter, but the two differentiating point is that it involves both ureter. Second, that the whole length of the ureter is stiff. The other is the retroperitoneal mass, and it can be easily differentiated from the retrocaval ureter, is that retroperitoneal mass compression causing lateral deviation, not medial deviation of the ureter. So this is important point to understand. Now let come into investigation, like we will be advising ultrasound as 80% of the patient are symptomatic. So first we will be going for ultrasound that will be showing hydronephrosis, and then we will go for the gold standard investigation, and that is the CT urogram. And then again we will be needing ultimately dynamic scan like MAG3 or DTPS scan to tell us about the degree of obstruction. And how to manage it? The management again depend upon the kidney position, that is the hydronephrosis. If there is a mild hydronephrosis and the patient is not symptomatic, just like that of piezo, treat that the patient in that line of direction. If the patient having recurrent UTI, the patient forming a stone, or there is a grass or moderate hard necrosis, so in that condition we will be going for surgical option. But if there is a mild hard necrosis, patient asymptomatic, we can treat the patient conservatively with the screening the patient regularly at 6 months or 1 year with ultrasound and labs. Now, how to operate it, or what are the surgical option? The surgical option, like we can resect that stenotic part of the ureter, or we can just left behind that and see to if we are unable to resect that portion, and then we will just re-anastomosis the ureter, or we can also go for ureteropelvic anastomosis, and we can go for through open surgical approach, laparoscopic approach, and through uh, open procedure or robotic procedure, and we can go also through transperitoneal or retroperitoneal approach, and we can go also through a plank incision. So this was all about the retrocaval ureter.